webinar. So today we are presenting the webinar on surgical resection of brain tumors presented by Dr. AHMED ABD EL-AZIZ HEGAZY. He has extensive experience in skull base and vascular surgery, worked on a number of significant research projects. He also introduced a new subspecialty of extracranial to intracranial bypass and undergone fellowships in a number of world-renowned centers. Dr. Ahmed currently holds the position of Professor of Neurology, Neurosurgery at Cairo University in Egypt. I welcome you, sir. So without any further delay, let's get started. Now I'm handing over the session to Dr. Ahmed.
How are you, Famila? I'm very happy to be with you today. And
Fine, sir. How are you, sir?
fine, thank you very much. And my deepest regards to you and to Mr. Ranjit as well. I would like to, first of all, introduce myself to you. I am currently a professor of neurosurgery at Qasalaini Medical College, Cairo University. Actually, I've been there since I was 18 years old. So I'm now 51, so I went in and I never went out, actually.
Wow,
So,
that's really impressive, sir.
yeah, I'm also very proud of our medical college because it is one of the leading medical universities throughout the whole world. It is the oldest in the Middle East and in Africa. And it is a huge facility. We have 6,000 beds. So I've been working there for something like 30 years right now. And it is ranking as one of the elite top 5% medical universities worldwide. We do all take pride in Cairo University because it's been serving the poor patients from all over the Arab world for a period of 3 centuries right now. Nuero Espitalia Neuroscience Center is the private neuroscience center where I operate my private cases. It is the only dedicated private neurosurgery hospital in the Middle East. It is a new hospital. It is very highly equipped. It's been functioning for 5 years now. It is very highly equipped. It has all the equipment that you can think about. It has a dedicated angiography suite. It has a neuroendoscopy unit, all forms of neuroimaging, stereotaxy, image-guided surgery, whatever you can think of that can be present worldwide, you name it, we have it. One thing that one has to mention, of course, is that we always become good surgeons by standing on the shoulders of giants. And I was extremely lucky and extremely fortunate to be able to work with the best in the business of neurosurgery worldwide. My first mentor was Professor Dr. Vinko Dolens. He was practically the guy who invented skull-based surgery. I stayed with him for a very long time, and he was almost like a father to me at the University of Ljubljana. And what he taught me, I still am in debt to him today. I've also worked with Professor Laligam Shekhar at the Harborview Medical Center in Seattle, Washington State University. He's the president of the society, the World Society of Skull-Based Surgery. He's a leading skull-based surgeon, he's a genius, and he's one of the most intelligent people I've ever had to deal with in my life. I've also worked with Professor Werner Irwin Hassler in Germany. During my days in Germany, he was the head of the neurosurgery clinic in Wedau Kliniken. He was a very kind man, and he always liked to help people from the third world. So that's why in his department, you'd always find people from all over. I was from Egypt. There were also people from Palestine, India, and so on, because he really liked to extend a hand to people from the less developed countries. He also sent me to work with Professor Dr. Peter Schmiedek, who was a leading bypass surgeon in Germany. He was the only one doing bypass surgery in Germany at that time. And I wanted to learn bypass, so Dr. Hassler referred me to Dr. Peter Schmiedek personally, and it is there where I learned bypass and was able to introduce extracranial to intracranial bypass surgery in the Middle East in 2007. I can never forget my best friend, Dr. Atul Goel, from King Edward Memorial Hospital in Mumbai. I stayed in Mumbai for 6 months, and this guy was like my big brother, and he taught me everything that I know about craniocervical junction, and he really never kept anything to me, and I never really felt while being in India that I was being in a foreign country. It was exactly like home, and mainly it was because of this guy. So today I would like to speak about brain tumors in general, and I've chosen a topic because, brain tumors are extremely wide variety of disorders. So I've taken one of them, which is a very common brain tumor, which are phenoclinoidal meningiomas. This is one of the fields where we have extensive research, and we've published a lot on phenoclinoidal meningiomas. You can also find this off of the internet and PubMed, and also they really represent something like 40% of all benign tumors that take place within the brain, and that's why they're very highly significant. They usually might present with visual disturbances. Something that is often missed also is cognitive dysfunction, because these patients might come with cognitive disturbances, and treating doctors never really take care of cognitive issues. The family would also notice this very early, and this can also lead to an early diagnosis. Many of them start to develop features of elevated intracranial pressure. Some of them have trigeminal nerve symptoms related to cavernous sinus involvement, like extraocular motility disorders, and many of them would develop features of brainstem compression in very large tumors. One thing that you have to understand is that also, because we live in this part of the world, patients usually come to us with delayed diagnoses, and that's why the tumors that we have to face over here are very much different from the tumors that usually the neurosurgeons in Western Europe and North America would have to face. And that's why things get a little bit more complicated for us. And that's why every country would usually tend to have its own experience, and it should have its own agenda and its own vision in how to treat those patients. And that's why treating those patients is often more difficult than in other parts of the world. And the choice of treatment is an extremely important issue that most neurosurgeons have to take care of, because at this point, the available choices include surgery, radiosurgery, endovascular embolization, endoscopic resection, and so on. Even the approach itself might differ from one patient to the other, and that is why it is extremely important that an experienced neurosurgeon would be able to know through his experience how to tailor the treatment according to every specific case. The surgical approaches that are available for resection of these tumors include the subfrontal approach, bifrontal approach, pterional approach with its various modifications. But the approach that we use in most of our cases is the frontotemporal epidural approach, with the mobilization of the outer layer of the lateral wall of the cavernous sinus, followed by a transsylvian resection. We've been using this approach for something like 20 years right now, and it's served us pretty well because it makes us see everything. These tumors really are a test of the neurosurgeon's own experience, because the more experienced the neurosurgeon is, the more he's likely going to be able to avoid getting into trouble and going to be able to know how to get out of trouble. The difficulties that can be encountered during surgery include bleeding, of course, problems with dissecting blood vessels and nerves, which is neurovascular dissection, intraoperative vascular injuries, and difficulties in achieving radical resection. One thing that I would like to add in these cases is that the experience of the neurosurgeon does play an important role, not only because this is the way he can avoid complications, but because in many cases, in these complicated cases, you don't have to make a mistake to be punished. Sometimes you can even be punished without making mistakes. So you have to be prepared for every single case scenario, and you have to have the knowledge and the expertise how to deal with every single case scenario, because this might make a difference between life and death for any patient. Now, here I would like to show you, this is a small movie on the surgical resection of these tumors. In many cases, after I came back from the United States, I used to open the neck in order to secure the blood vessels. Here you can see the common carotid artery, the internal carotid artery, and the external carotid artery, the 12th nerve, and this is the posterior body of the digastric muscle. Because when I was working with Dr. Shaker, in these cases, he would usually expose the neck in preparation for a bypass and in preparation just in case vascular injury would take place. Then, after opening the skull, this is the division of the tentorial duplicator and the mobilization of the outer layer of the lateral wall of the cavernous sinus. Here you can see the exposure of the V1 and V2 and V3. This part of the operation is usually bloody, but this usually helps very much to devascularize the tumor, so that when we go intradurally in order to resect the tumor is actually completely and totally devascularized. It makes life a lot easier. So here you can see the resection of the tumor itself. This massive structure that you can see is the tumor, and we are now delivering the tumor from within the brain. You can see the tumor is whitish. This is a very highly vascular tumor, and because of the mobilization that had been done extradurally, the tumor is now completely devascularized. So this makes life a lot easier for the neurosurgeon and for the patient as well. Many centers worldwide don't use this technique, and that's why they usually have a lot of difficulties with these cases. They are difficult cases, but they definitely can be made easier once the neurosurgeon has in his armamentarium this variety of techniques of how to use them for the resection of the tumor. Here you can see the tumor resection proceeding, and it's always, while dealing with these tumors, it's always like navigation. You have to reach one structure, and then from this structure here you can see the middle cerebral artery, and then we dissect the tumor from the middle cerebral artery, and then the tumor is dissected from the tentorial edge. Here you can see the third nerve has started to appear, and now the carotid artery is seen. After resection, you can see that the vascular tree is completely dissected. This is carotid artery, PCOM, anterior choroidal artery, ACA, MCA, the optic nerve. And in these cases, this is the third nerve as it enters the cavernous sinus. And in these cases, it is always very gratifying in the end when you can see the normal anatomy all the way to the basilar artery, and the tumor has been completely delivered here all in one piece. Here you can actually see all the way down to the basilar artery, and the tumor is completely removed. These patients usually do well after surgery, and the post-operative period is usually uneventful when things go well, just like that. So it is important that the neurosurgeon will be able to know how to work safely in these cases. One thing that I would like to point out also is the neurosurgeon has to be able to dissect blood vessels correctly. And the best way of dissecting blood vessels correctly is by working through the sylvian fissure. The neurosurgeon has to have a very, very dedicated knowledge of the anatomy of the blood vessels of the brain, how to deal with the blood vessels of the brain, how to dissect the blood vessels of the brain. The neurosurgeon must be able to work around them, between them, through them, and in many cases work on them. Here you see the technique of splitting of the sylvian fissure. This is a very important technique that every neurosurgeon should do, and they should use very oftenly. Using sharp and achromatic dissection, the neurosurgeon should be able to work through the blood vessels in order to expose the blood vessels at the base of the brain, and this will definitely give him an opportunity to be always working under vision, knowing where he's going, and using the blood vessels as a roadmap that can always tell the neurosurgeon where he is inside the brain. And this step should not be overlooked because the neurosurgeon should always take his time. I've seen many of the neurosurgeons worldwide who can do this very well. Many of them take up to 3 or 4 hours just to split the sylvian fissure, because once the sylvian fissure is split and you have a good visualization of the blood vessels at the base of the brain, life becomes a lot easier and things become a lot safer. Here you can see the blood vessels after being exposed. Now we know exactly where we are. Now we know exactly what can be done, step by step, taking things one step at a time would always bring you to the result that you need once you know what you are doing. Problem with a lot of neurosurgeons worldwide who are not dedicated to brain tumors. They really don't have the knowledge of how to perform these steps correctly. And that's why this results in catastrophic results in many cases. Here you can see the wide exposure. This is the frontal lobe, this is the temporal lobe, and here is the middle cerebral artery bifurcation. You can see now the exposure going all through. This is a very good way of working because once this happens, you work exactly under vision, you know where you're going. Now I'll show you some cases. The first case is a middle-aged female who presented with diminution of vision on the side ipsilateral to the tumor, in addition to a severe cognitive deficit associated with features of elevated intracranial pressure. Here you can see she was diagnosed as having a clinoidal meningioma. This was a very vascular tumor. And you can see in this particular case, the blood vessels are engulfed by the tumor. So it was not just about resecting the tumor, but about also dissecting the blood vessels that have been engulfed by the tumor. We managed to see the blood vessel tumor is extremely vascular. We've managed to take out this tumor completely. This is the post-operative imaging showing the complete resection of the tumor. You can see there's no tumor left at all. And this patient, in spite of a good resection, in spite of everything, she had a very stormy post-operative period. So it is also very important, I told you, you can still be punished without making mistakes. So it is essential that a neurosurgeon would know what he's doing and be prepared to deal with every possible complication that can come up. This is the second case, a 55-year-old lady who presented with headaches and diminution of vision in the left eye only. She had a small tumor, and actually, whenever I see small tumors in this area, I start to become more and more afraid, because if a small tumor gives early manifestations, this means that this is not going to be an easy task. You can see the tumors also completely engulfed the blood vessels and was surrounding the bone at the base of the brain. The tumor here has been dissected with great difficulty. And this patient had a total tumor resection. And after surgery, she went into vasospasm. And it took us 40 days in order to get her out of the intensive care. But finally, she went back home very well, in an excellent clinical condition, and was doing well. So it's not only about doing surgery, it's being able to manage complications and diagnose them and treat them promptly whenever they can take place. Another case is a 46-year-old driver who presented to us with diminution of vision and fits. As you can see, the carotid artery, which is the main blood supply to the brain, lies completely within the tumor. So we went in again, and we spent a long time dissecting the blood vessels, and we were able to completely resect the tumor. You can see a complete tumor resection at the end of the case. And it's also very gratifying when you have such patients doing well after surgery. Another case is a 55-year-old housewife who presented with features of elevated intracranial pressure and cognitive deficits. You can see that she doesn't have any brain left, actually. All you can see right now is the tumor, which is this white patch that you can see on the left side of the picture. But anyhow, this tumor was removed completely, and the patient was able to go back home safely, and she continues to lead a normal life. One thing that really, when I first started doing neurosurgery, something like 25, 30 years ago, I was only caring about operating these patients, operating big tumors, operating big cases. And as one started to grow up and become more and more wise, one started to develop an awareness of the quality of life. Because sometimes you can manage to take the tumor out completely and the patient is neurologically free, but he still cannot have a normal life. The quality of life is very important, because patients might, in many cases, might still go on to have visual disturbances, cognitive dysfunction, or epilepsy. So a surgeon's job does not end only with the resection of the tumor and with the patient going out of the hospital. A surgeon's job is only ended when the patient can go out of the hospital and lead a normal life. And that's why I take very good care of these patients, and I insist that they would be able to go back to their normal daily life. Because, for example, if you have a patient with a cognitive dysfunction and he's working as an accountant, he cannot work anymore. If you have a patient who's working as a driver and he's continuing to be epileptic, he can't work anymore. He can't earn a living. So it is extremely important for a neurosurgeon to understand that his job, especially when operating brain tumors, it does not end with the resection of the brain tumor or even with the patient leaving the hospital. It only ends when the patient can go back to his normal daily life and earn his daily living and deal with his wife and kids and deal with the world around him. And that's what makes neurosurgery beautiful. And probably that's what makes it difficult. It's the agony and the ecstasy of neurosurgery. Thank you. Mr. Ranjit? Ms. Fadia?
Yes, doctor. Wow, doctor, that's really a great presentation. So, friends,
Thank you very much.
I hope you all got a new knowledge about this from this webinar. And now it's time for your questions. If you have any questions, kindly raise your hand and you can ask the doctor one by one, or please feel free to type them into the chat box. Anybody have any questions? Yeah, Ramya.
Yeah,
Good day. How are
good
you,
day,
Ramya?
sir. Fine, sir.
I'm
What
fine.
about you, sir? Sir, I have a question. How long does it take to recover from brain tumor removal surgeries?
Well, with complicated cases, usually the patient, we usually would like the patient to stay in the intensive care overnight, immediately after we operate the brain tumor. But this really, recovery from a brain tumor really depends on the location of the brain tumor and the difficulty of the case. In straightforward cases, the patient might recover the second day after surgery, and in many cases, in most of our cases, they are discharged 2 days after surgery from the hospital. But in many other cases, they might take a little bit longer because some patients come to us in a bad condition in the beginning. Some patients come to us with bulbar paralysis, with weaknesses, so they need a little bit of rehabilitation after surgery. So this really depends on the nature of the brain tumor, where the brain tumor is in the brain, and whether it's a benign tumor or a malignant tumor, whether the resection has been complete or incomplete. It depends upon a lot of factors, but usually, in most case scenarios, usually the patients stay in the intensive care overnight and usually leave the hospital on the second or third postoperative day. They come to us back again on the 15th day for removal of the stitches, and then they're good to go. They're good to lead their normal life. This is also very important because, many of our patients come from all over the world, and I would like you to be referred to my website at the end of the lecture. My Facebook page, you will find testimonials from many patients from all over the world. We get patients from all over Africa, the Middle East, of course, from Europe. We get patients. We've had patients also from the United States. So I would like you to go in and see those testimonials and see how those patients describe the experiences, because every patient has his own experience. So it is important to see things from the patient's perspective. But with the usual thing, patients would usually get out of the hospital within 2 days or 3 days, and they usually go back to their normal life within 2 weeks. Does this answer your question, Ramya?
Yes, sir.
Thank you very much.
Thank you, sir.
Jibanga, you have any
So,
question?
Hello.
hello.
Hello. Good afternoon. Hello. Good afternoon.
Good afternoon. How are you?
I'm fine. My name is Benga. I'm talking from Nigeria.
How are you?
My question. I'm fine. And you?
I'm fine. I've had quite a lot of patients
Okay.
from Nigeria, actually.
Oh, okay. That's good. I know that we've been sending a couple of patients to your hospital.
Very good.
Anyway, my question goes thus: can hydrocephalus turn to a brain tumor?
No, hydrocephalus cannot turn to a brain tumor, but brain tumors can cause hydrocephalus.
Okay. Okay, that's the question now.
Yeah, because you see, a lot of brain tumors come to us, and they compress the normal CSF pathway in the brain. And that's why these patients develop hydrocephalus. So in these cases, the removal of the brain tumor should be associated with a resolution of the hydrocephalus. But not essentially, the resection of the brain tumor would cause a complete resolution of the hydrocephalus, because even with complete resection of the brain tumor, some patients may persist to have hydrocephalus. And these patients might need shunting after surgery, because when there's a brain tumor in the beginning and the brain tumor causes hydrocephalus, it's called obstructive hydrocephalus. But after resection of the brain tumor, a lot of protein goes into the subarachnoid space. And this causes a delay in the CSF absorption. So even with radical tumor resection, some patients might continue to have a communicating hydrocephalus, and they still might need shunting. So the neurosurgeon should be always on the watch for hydrocephalus, both before surgery, during surgery, and after surgery, because removal of a brain tumor does not necessarily mean that the patient will not be having hydrocephalus after surgery. So this is a very important question. And because especially that after surgery, when hydrocephalus manifests in a tumor, it doesn't really manifest in a classical way like it takes place before surgery. It is usually not associated with features of elevated intracranial pressure. Some patients might develop CSF leak, CSF rhinorrhea. Some patients might develop pseudomeningoceles. And usually, because this is a chronic and slowly developing hydrocephalus, usually the manifestations are usually masked by other symptoms of disease. So the experience of a neurosurgeon plays an important role in these cases in order to detect them and treat them promptly. And this is very important because it makes a huge difference for the patient. Does this answer your question?
Yeah, thank you so much, Doc. I appreciate it.
Most welcome, most welcome. And now we have Dr. Mutaleb.
Hello.
Hello, how are you?
Yes, sir. Good evening from Bangladesh. Dr.
Good
Mutaleb, it was
evening.
nice presentation.
Oh,
And
good evening. How are you?
Yes, sir. Fine, sir. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam wa barakatuh. I have very good friends in Bangladesh, actually.
Yes, thank you, sir, very much indeed. I have one question to you. I'd
Yes.
like to ask you about malignant brain tumors, its prognosis. Could you tell a little bit, please?
Yes. With the most common malignant brain tumor is the glioblastoma multiforme. And the glioblastoma multiforme, unfortunately, does not have a good prognosis. The prognosis is usually the expected survival with radical resection, with radiotherapy and chemotherapy. The survival does not usually exceed 2 years. So whenever there's an established diagnosis of glioblastoma multiforme, the prognosis usually is not very good. So this is a fact of life, and that's actually where most of the research for malignant brain tumors is going, in order to be able to deal with the genetics involved, with the immunotherapy involved. And actually, I have a colleague of mine who's been able to publish on glioblastoma multiforme, and he had breakthroughs with immunotherapy, and he was published in Nature. So he's a very good friend. He was actually a classmate of mine. But generally speaking, the prognosis in glioblastoma multiforme, even with radical resection, is not good, which is the most common malignant brain tumor.
So what's about complications?
Well, with malignant brain tumor surgery is often an easy surgery. It's usually not associated with complications, with that much complications. And in my humble experience, even when complications develop, like the presence of a neurological deficit or so, they usually recover easily within a few weeks. But the prognosis regarding the quality of life and the life expectancy of these patients is usually not good, even with radical resection in most places throughout the whole world.
Okay, sir. Many, many thanks. Thank you very much indeed.
Most welcome, most welcome, most welcome.
Next one, Ravi.
Okay. Hi, doctor. Good afternoon.
How are you, Ms. Ravi? How are you?
I'm fine. I'm talking from Nigeria.
How are you?
I'm fine, sir. Thank you for having me.
Most welcome.
So my question is, how do you take care of a patient who has this recurring seizure let's say the seizure always reoccurs after 3 or 5 days, and again, the person who undergoes brain resection, after that, he was advised not to take some certain antibiotics that could trigger those seizures. So how do you take care of those patients with seizure after brain resection? Thank you.
Well, this is very important because seizures are a frequent occurrence in the post-operative period following brain tumor resection, and they have to be stopped at any cost because we give intensive medical treatment to stop the seizures. We give brain dehydration, but if things are necessary, we have to put those patients even under anesthesia sometimes. Sometimes we have to place them under anesthesia because seizures could be persistent seizures, could be catastrophic, and they can kill the patient sometimes. So they have to be stopped at all cost. And they have to be treated, of course. The drug of choice in treating seizures usually is the levetiracetam and the epanotine, which is the dilantin. And we give them on an intravenous dose, and we monitor the serum level of these drugs because it's very easy to get these patients with intoxication, with drug toxicity. So seizures have to be stopped. Imaging is also very important in these cases because the cause of, if there's a treatable cause for persistent seizures, it has to be treated. Some patients might have hematomas. Some patients might have venous thrombosis. Some patients might have dehydration. So it is important to investigate those patients thoroughly in order to know where the cause of the seizure is. And the cause has to be treated. But in any case, the seizures have to be stopped. One thing that I would like to point out is that in many cases, the seizures are not convulsive. Some of the seizures are subclinical seizures, and they manifest themselves as changes in heart rate, blood pressure, and respiratory rate. So some of them come on an autonomic level. So the intensivist and the neurosurgeon have to always be on the watch for treating those cases, and they have to be treated with anti-epileptics, and they have to be treated rapidly, and if necessary, the patient should be put under anesthesia. So does this answer your question?
Yes, doctor. Thank you. I have a sister actually who always have this reoccurring seizure, and she's always convulsing. So that is the reason why I asked the question.
And
Thank you.
she had a brain tumor before, or she has seizures without a brain tumor?
It's just seizure without a brain tumor.
Yeah,
But
because
it's always a reoccurring seizure. It always reoccurs after 3 or 5 days.
yeah, well, you see, this is very important because I've been operating patients with epilepsy for more than 20 years now. So whenever we have a patient who is failing medical treatment, this is what we call medically resistant epilepsy. Now, it is very important for these patients to be categorized into two groups. One group is patients with persistent epilepsy because of failed medical treatment who have a focal epilepsy. That means that they have one focus within the brain. The second group is the group of patients who have persistent, medically resistant epilepsy who are multifocal. They have many foci within the brain and many foci that are present on both hemispheres. So these patients have to be investigated through, first of all, a video EEG, a long-term video EEG. We perform a long-term video EEG for 24 hours, sometimes for 24 to 48 hours, a long strip EEG. And the EEG will show us whether the epilepsy is focal or generalized. And if the focus is a single focus and whether the single focus is present in one lobe or more. If the patient has a single focus, usually the focus is in the temporal lobe. These patients do very well after temporal lobectomy with amygdalohypocampectomy. If the focus is multiple, this is a completely different issue. But these patients have to go through this battery of investigations because if they have a single focus, there's a very good chance that they can be helped surgically. And we've been doing epilepsy surgery actually for a very long time and with very good results, especially for patients with temporal lobe seizures. Patients with temporal lobe seizures usually do very good after surgery, and we have had many patients who've even stopped taking medications, which is what we say is an Engel grade 1. This is a very good achievement. So I suggest that your patient would be investigated this way to know whether this is a focal or multifocal epilepsy and whether the focus is, if it's a single focus, where the focus is, whether if it's in the frontal lobe, the temporal lobe, the parietal lobe, and so on. So this is the best way to help him. And if you would like me to help her, just send me a note through Mr. Ranjit and we'll do everything that she needs.
All right, doctor. That is very good. Thank you.
Most welcome. Most welcome.
All right.
Yeah, now Bhujar, do you have any question?
Yeah. Hello, doctor.
Hello, how are you,
you?
Boja?
Yeah, I'm fine, doctor. It was a good conversation. Will the brain tumor surgery result in memory loss?
Yes, some patients come to us with memory loss before surgery. And usually after surgery, the memory becomes a lot better. You see, there are two forms of memory. There's long-term memory and there is a short-term memory. Now, long-term memory is usually widely distributed throughout the whole brain. Unlike short-term memory is mainly present in the temporal lobe. So patients who come to us with cognitive deficits generally usually describe a vague memory deficit. And this usually improves after surgery, especially for benign brain tumors. This usually improves after surgery. And we've run actually a randomized control trial on the cognitive outcome following the surgical resection of sphenoclinoidal meningiomas. And we have realized that with a more radical resection and good neurosurgical technique, those patients can experience an improvement in their cognitive functions after surgery, which is very important.
Thank you, doctor.
Most welcome.
Doctor, in the chat box, Abdul asked that, do you think using mobiles and laptops for a long period of time causes brain tumors, or is it just a rumor out there?
Well, yeah, this is a controversial issue. This is a controversial issue, and we deal with brain tumors every day, but I cannot, because, you know, I'm quite an old guy. I'm 52 years old right now. So I've been operating brain tumors in the era that preceded the appearance of the mobile phone. And I'm operating brain tumors every day up till now. But I cannot really tell you that there is an increase in the number of brain tumors that we have operated ever since mobile phones started to appear. There has been research that was done on primates, and some primates showed a slight increase in the number of malignant brain tumors when exposed to the mobile waves. But again, there has been a lot of research that suggested that there is no increase in the incidence of brain tumors in the presence of mobile waves. So I don't really know whether this can affect the incidence of brain tumors, but we really have not noticed any difference in the incidence of brain tumors in the pre-mobile phone era and in the mobile phone era.
Thank you, doctor.
No problem.
So, doctor, I wanted to know what precautions should be taken after brain tumor surgery, doctor?
Well, after brain tumor resection, it is extremely important. Usually, I tell my patients that close follow-up is important. So I would like to see my patients in my clinic 15 days after surgery, and 3 months after surgery for 6 months, and then every 6 months for 1 year, and then I would like to see them on a yearly basis. So follow-up is very important because even if a brain tumor is benign, even if a brain tumor has been totally resected, even if the patient is doing great after surgery, this does not mean that a recurrence cannot take place. And dealing with the recurrence is always a much more difficult issue than dealing with a primary brain tumor. So, and when the recurrence is diagnosed early, the patient can be saved, because we've had recurrences with malignant brain tumors, and we've had recurrences with benign brain tumors. And that's why whenever we have a benign brain tumor, it's important to run a genetic workup for the tumor, because many benign brain tumors don't have a propensity for recurrence. And again, many benign brain tumors have a propensity for recurrence. So the only thing that can be done in these cases is usually a very close follow-up in order to save the patient whenever it is necessary. Follow-up is very important, both clinically and radiologically. So it's important that these patients would stay in contact with their treating doctor. In many cases, I give my patients my own personal WhatsApp number, and I tell them to be in contact with me directly if they have any problems, if they feel anything new, if they have recurrence of their symptoms, just to inform me immediately, because early diagnosis is always very important.
Thank you so much, doctor. Does anybody have any questions?
Doctor, is there any food that we need to include in our daily diet? It can prevent brain tumor or anything related to cancer in general.
Well, regarding a daily diet, and
maybe any food, like any fruits or vegetables, like what do you think should be the one that we should include in our
Well, I really don't know, but there has been a lot of research lately on the use of what they call the keto diet, or the ketone body induction. And but this has not been done in patients who do not have brain tumors. It has been done in patients who already do have brain tumors. And it has been found that patients who follow an induced ketosis with a vegetarian diet usually do better than patients who do not have an induced ketosis. But this theory, although it did function to some extent, it really did not attract so many followers worldwide, because when it comes to these issues, usually there's a lot of politics going around. So, and for example, I've worked in India for a long period, and I think that the time that I spent in India was probably the best time of my life. And I enjoyed my stay in India very much. And India is the country with the largest number of vegetarians throughout the whole world. And in spite of that, India does not have a lower incidence of brain tumors than in the Middle East, for example, or in places like that. So I don't think that diet really plays a role regarding the occurrence or the incidence of brain tumors, but it does play a role in treatment of, it may play a role in the treatment of brain tumors. I hope this answers your question.
Yeah, sir, but is there any, because I've heard papaya is very good for health, like in cancer. to prevent. So is there any specific fruit, like I'm asking, is there anything like that, or?
Well, I really don't know, but I think fruit in general helps. But whether there is research, solid research that supports this issue is none that I know of.
Okay, thank you, doctor.
Most welcome.
Any more questions? Okay, so thank you so much, Doctor, for taking your precious time to share your knowledge with us and conducting the very helpful webinar on surgical resection of brain tumor.
Most welcome, Famida. Most welcome. I enjoyed this session very much, and I hope it has been informative. And I hope that I've been able to share our knowledge with the audience. And also, I hope that they have come out with a good take-home message from this lecture. And I hope I'll be able to help you in any way I can in the future.
That's very impressive presentation, and also you have answered all our questions, Doctor. Thank you so much for that. And I also thank the participant for attending today's webinar. If you want to consult any doctor for any kind of treatment, you can contact Anavara. We encourage you all to connect with us on social media also. If you have any additional questions, you can contact us by mail or telephone, and we are really happy to provide you with additional support. Once again, thank you so much, everyone, and have a good day.
Thank you so much, Famida.
Thank you,
Thank
sir.
you so much. Bye.
Bye, sir.